So my name's Mirette and I'm one of the trainees at Chelsea and Westminster Hospital. I have an interest in patient safety, and this slideshow has been prepared by myself and by the help of Dr. Jane Runnacles, who is a consultant paediatrician at St George's Hospital. So hopefully we'll make this an interactive and insightful session, and if you have any questions or anything that you'd like to ask, then feel free to ask in the middle or pop it in the chat box, and I'll try and get to it as we go along. Okay, so we're going to talk today about the Swiss cheese model and SEEPS model very briefly, just to put it into context with what we're going to talk about today, which is mainly about human factors and how human factors affect us as trainees and as clinicians on the shop floor. And we'll then look at situations where errors are more likely to occur, and think about some of the cognitive biases that we might come across during our clinical practice and how we can mitigate those, and then a little bit about situational awareness and safety huddles, and a quick interactive quiz at the end. Okay, so many of us are probably quite familiar with the Swiss cheese model, in that it's been around since the early 2000s, and it was created by a gentleman called James Reason, and he, coming from a non-medical background, was able to characterize the situation in which we find ourselves on wards and in clinical environments. And he was saying that the poor nurse at the front line who accidentally gave 10 times the amount of IV morphine isn't the person to be blaming here in that situation, and that it actually is a result of a wider system of errors that tend to occur that have then caused this situation to arise. So when thinking about that example, we think about the latent errors that might be inbuilt in the system. So, for example, the doctors and nurses in that hospital working very long hours, very little time to rest in between shifts. That will obviously play into it. Management decisions such as staffing and making sure that there is enough staff on the ward. Thinking about error-producing factors such as, for example, if there is still handwritten drug charts, is it that the drug chart, is it that the handwriting isn't quite legible and therefore the decimal point was in the wrong place? Thinking about the task itself, was the nurse being distracted while she was drawing up the medications? And then thinking about the active failures. So, for example, where we know that there should be 2 nurses checking a drug dose in between before it's given IV, was that perhaps not the situation, and did error arise because this wasn't done on this occasion? And then thinking about other defences. So, was there a pharmacist there, and why was it not picked up by the pharmacist, or was the pharmacist absent at the time? Those sorts of things help then to look at it from more a system-wide perspective in understanding then why errors occur. And then more recently, the SEEPS model has come and become more popular in terms of patient safety literature, and it looks to see how, again, it's identifying that there is a system-wide approach to be thought about, but it puts the person at the center. So the person being the clinician or the patient, and looks at how that person then interacts with all the other things in their environment. So the internal environment, the external environment, how they interact with tasks, technology, organizations, and then how those interactions map out into processes, and then how those processes result in the desired outcomes that we would like. And so today we're going to talk about ourselves as being the person in the middle, and how we can think about our own biases, our own areas in which we're prone to error, and see how we can reduce those in order to improve patient safety. So what about me in the front line? So can you have a go at reading this? It gets a bit easier from reading about third line on. And in general, most people will find it quite easy to read. So just tap into the text box yes if you're able to read it, no if you weren't. Yep, so we're all pretty quick at being able to, our brains are pretty quick at being able to join the dots, and even though you don't have the whole word, your brain is able to put it together so that you can come up with the word and that you're not reading each letter and number by itself. Okay, so then we're going to try the next thing, which is, can you quickly calculate, give you 10 seconds to quickly calculate what's 8 times 7 times 6 times 5 times 4 times 3 times 2 times 1 without using a calculator. So to make it easier, here's some ballpark figures. So if you could just type into the text box roughly what you think it might be. 500, 1,000, 2,000, 3,000, 4,000, 5,000, 10,000, 20,000, 40,000. Just roughly, what do you think it is? Go. Okay, we've only got one answer so far. Anyone else able to type quickly? Oh, okay, wow. You guys are actually much better than the general public. So when the general public were given this question, they said that, like, when given just 10 seconds to think about it, most people put in the answer C, so about 2,000. And we'll come on to that later on in the talk to see why that's relevant. But I just wanted to emphasize here how we quickly tend to make some calculations. So whoever wrote 40,000, you are spot on. It's more like 40,302 or something like that. But yeah, you're much better than the general population. What we tend to do is take the first few numbers and think, oh, it must be something quite big, and so then we go for something big. I'll come on to why this is important later on, but yeah, so the point is that we try and use information quickly in a way to try and come to conclusions. So another quick question then, and you might be just as good as this. This question: there is a bat and a ball collectively, they are £1.10, and the bat is £1 more than the ball. How much are they each? Quickly, can you write in an answer in the chat box? Anyone? So Severa, I think you're really good at this. So most people, right, they would say that the bat is £1 and that the ball is 10p. But you're right. So it's that the bat is £1.5 and the ball is 5p. So as to make this answer correct. So yeah. Our brains are good at quickly thinking, but might not always come to the right conclusion. But Severa is an exception. And so this highlights thinking fast, thinking slow, type 1 and type 2 thinking. where our minds use heuristics, which are quick getaways or quick fast rules in order to make decisions, because we're making so many decisions along in our day. And type 2 thinking is more slow, calculated thinking. And because it's more time intensive to have type 2 thinking, type 1 is designed to help us get through certain things quickly. So many people in patient safety spheres will recommend this book by Daniel Kahneman about thinking fast and slow. So that's about our thinking. Then what about our perceptions? So looking at this, would you say that the lines are crooked or straight? So most people would say that the lines are crooked, but it is mainly because of the way that the boxes are placed that they look crooked, and actually these are all parallel straight lines. And what do you see in this situation? So up close, you might just see some zigzags. If I encourage you to take a step back from your screen, like maybe 2 steps back from your screen, can anyone see anything different? Yeah, absolutely. So a panda comes into view, and that is a very great example of how our perception changes when we take a step back. So the things I wanted to highlight here is our brains are extraordinary. We're able to like join up the dots very quickly and do some very quick calculations, but apart from Severa, sometimes we can get it wrong, and our brains can be limited. Our perceptions of situations is the other thing I wanted to say, might not always be the full picture, and so sometimes we need to take a step back in order to process the situation. And so Vincent et al. Looked at some situations in which errors arise and found that there were a number of situations in which that predispose to errors occurring. So where the person is unfamiliar with the task or inexperienced, where they are rushed or have short of time, where there's been inadequate checking or there's poor procedures in place, they are more likely to have risks, so errors occurring. And they've also found, and I think we can all relate to it as well, is where there's poor human equipment interface. So whenever you're having the IT issues, that tends to be the situation in which there's always something that then happens. And thinking about our own selves, so we've already acknowledged that we have a limited memory capacity and that we have limited working memory. But this can all be further reduced by fatigue, stress, hunger, if we're not feeling particularly well that day, by language and cultural factors, and by hazardous attitudes. And a lot of work has been done recently regarding tiredness within the medical spheres, and I know Mike Farquhar does a lot of promotion for adequate sleep for clinicians. And a recent study, well, fairly recent study from Nature found that 24 hours of sleep deprivation is about the equivalent of 0.1% blood alcohol. And thinking about the complexity of the work we do and about what high risks are at stake if errors go wrong, if errors do occur, then we put it into context with, say, commercial drivers who drive heavy goods vehicles, and we realize that 24 hours sleep and deprivation is about the equivalent to what is just about considered safe for a heavy goods driver in Austria to be working. And so it can't be emphasized enough how fatigue and tiredness can really impact our work, as can stress. So we all are pretty familiar with high stress situations being a perfect medium for errors to occur, but this parabola shaped graph shows us that low stress can also be a situation where errors occur. So think about if you're still in a place where drug charts are written manually, handwritten, I mean, where if you're, for example, the SHO on the neonatal unit and 22 blah, blah, blah has been there for absolutely forever, and you're copying out the numerous medications that they're on, that might be a low stress and quite boring task, but it can be a situation of error occurring because the brain is not quite so engaged, and therefore error might be prone to arise in those situations. So it's helpful for all of us to be mindful of the fact that low stress situations and high stress situations can reduce our performance. So whenever we're hungry, angry, or late, think halt. We need to stop and think about what we're going to do to mitigate that in order to help improve our performance on that day on the shop floor, knowing that these are the situations that can increase or predispose to errors arising. And coming from the aviation industry, they came up with a checklist saying, I'm safe. So thinking about these sorts of factors, illness, medication, stress, alcohol, fatigue, and emotions, before a person flies a plane, as they've identified that these are all factors that can influence a pilot's performance. And I just wanted to touch on cultural and language factors, because often we think we've sent out a message to someone, we've communicated in some way, but the receiver may not always receive the same message that we've issued. And so it's important to make sure that we are able to kind of check each other's understanding of a situation, especially since language and cultural barriers can be compounded by assumptions that people make, by distractions, and that sort of thing. And so it's something to be mindful of when you're on the shop floor. Okay, so we'll talk next about cognitive biases and about how these can affect our perceptions when we are seeing the patient in front of us. So framing effects. So framing effects tells us that where the context in which we see a patient affects the way in which we see the patient. So for example, if you see a patient in the ambulatory unit, you might miss like a simple pneumothorax compared to if you saw that same patient in the resus situation, or where you've got more observations, where you're probably paying a little bit more attention to the chest x-ray, etc., etc. And so it's just as how this frozen yogurt has been framed in two different ways, either 20% fat, which sounds awful, or 80% fat free, which you think, that's quite good. Same in terms of medical situations, the way in which things are framed might influence our decision making. And ascertainment bias. So one of my consultants used to always say, the eye sees what the eye sees what the mind knows, in that we all have some preconceptions, and just as how some people in this picture will see the old lady and some people will see the young lady, our prior expectations or our previous experiences will influence the way in which we see something. And this is an umbrella term that can be used to also cover things like prejudices and stereotypes. So a clinical example would be if an adult doctor saw like a homeless guy who had previously been in because of alcohol intoxication or drug use, might assume that the unconscious patient in front of him, because of his previous history, is probably unconscious because of his intoxication, but would need to think about hypoglycemia, viral encephalitis, all these other things. And so it's important that we don't have ascertainment bias in terms of when we see patients in front of us. And another type of bias that we might have is confirmation bias. So this is once we've formed an opinion, we have a tendency to only notice the evidence that supports it, and we tend to then ignore contrary evidence. So, for example, if there was a 10-year-old autistic boy in the ED who came in with vomiting and abdominal pain, and he felt his tummy and it was soft, one might think that this is probably gastroenteritis, and keep going with the gastroenteritis scenario, that even if he's vomiting more despite the oral fluid challenge, we're still going along with the diagnosis of gastroenteritis and forgetting any other kind of opportunities to look for other diagnoses that it might be. So, for example, if the SHO who initially saw them forgot to look for a testicular torsion, for example, that might be missed if we engage with confirmation bias and just go along with what we think is the current situation. So in order to try and overcome that, we need to look for evidence of what we don't think it is. So in applying it to that same example, if there is a 10-year-old boy with abdominal pain and vomiting who's not tolerating his fluid challenge, think then about what else could it be? Is there something that we're missing? Go back and revisit the history and examine the patient again. So U order of effects relates to anchoring bias, and U order of effects tells us that we are best at listening to the information that is given to us right at the beginning and again right at the end, and that our attention tends to drop halfway in the middle and then rise back up again. And so that's important for us to appreciate for the next sort of bias, which is anchoring bias. This is where we listen to the first part of the history, for example, and then we prematurely settle on a diagnosis and become fixated on that particular diagnosis, and that label tends to stick. So, for example, if there is a teenage girl who comes in with headache, some vision disturbance, and a family history of migraine, it might be easy to label her then as migraine and to keep going with the headache as migraine. And if then further pieces of information are ignored, such as the nurse comes and tells you that she's very hypertensive, or that the mother comes in and mentions that it was a very sudden onset headache, that sort of thing, and we just cling to the initial information, then we might miss other diagnoses such as subarachnoid hemorrhage or benign intracranial hypertension or something like that. So important to be aware of this bias when we're meeting patients and coming up with diagnoses. And it's also something to bear in mind in handover. So sometimes situations may change, and so we've been given a particular handover about a patient, and we just keep going with that, whatever that diagnosis was, without then revisiting things with a fresh pair of eyes. And that relates very strongly to diagnosis momentum, again, where a patient has been given a particular label, and is then that is carried on through one handover to another without the diagnosis being questioned. So we had a case very similar to this recently, where it was a 3-year-old boy with a presumed viral induced wheeze, continued being treated as a viral induced wheeze, actually seemed to be getting better. So in all intents and purposes, we felt that he was a viral induced wheeze, but then wasn't really fully resolving, and later was subsequently found to have had an inhaled foreign body, which was subsequently retrieved. But it makes you just think that, like, sometimes if things aren't moving in the direction you are expecting, stop and rethink about the situation, and be aware of anchoring biases and diagnosis momentum. So affective bias is where our kind of assumptions about a patient may affect our perceptions, and it's a tricky one to kind of explain, but like it's where, if for example we have had like a very aggressive or riled up parent that has then made the consultation a bit confrontational, it might affect the way we then manage that child. So it's always helpful for us to be aware of this as a potential bias, so as to not mistreat or as to not to affect a patient's care because of personal predispositions. Availability bias is another situation that we could often come across. So with availability bias, there's two kind of sub biases to it. So that, so those are recent case bias and significant case bias. So if we've seen, for example, 3 cases of viral-induced wheeze, we can sometimes then think that the patient that we next see with wheeze is another viral-induced wheeze, and may miss, for example, that it is actually a wheeze with some crackles and that this is potentially a lower lobe pneumonia, for example. Or the converse to that is a significant case bias, where, for example, we have had a recent case of, I don't know, intussusception that was missed, so therefore like it becomes more heightened in the back of our heads, and so every child that comes in with abdominal pain, then we are highly suspicious of intussusception because of that recent case, even though it's a relatively rare diagnosis. So those sorts of biases are also important to bear in mind. And it's also important to bear in mind gambler's fallacy, that however many patients we've seen earlier that day with a particular diagnosis, it does not affect then the likelihood of the next patient being seen with that same diagnosis. So gambler's fallacy says that if you've flipped a coin and 10 times out of 10 it's been heads, the next time it doesn't necessarily mean it's going to be heads, and or that it's going to be tails, that it's independent of the previous 10 times, and therefore we have to take each clinical case that we see based on its own merits and not on likelihoods or probabilities based on previous experiences or like previous probabilities that day. Then another type of bias that I think we all can sometimes fall into is the blind spot bias, which is that unconsciously incompetent people may be more confident of their abilities than those who are consciously incompetent. So yes, the underskilled individual tends to overestimate their abilities compared to those who know that they don't know. And so that aha moment where we go from going unconsciously incompetent to consciously incompetent is a very important step that we all need to take in our clinical practice, so that we can then go on to move from conscious incompetence to conscious competence. And so just being aware that there are maybe things that we don't know is helpful in terms of not making any rash decisions and seeking help where we think we might not know what we don't know. And then I think this is the penultimate bias, so feedback sanction. So where we don't see the consequences of our error, it may predispose us to doing the same thing again and again. So this is kind of a bit of a facetious example, but if a clinician always uses a CT scan as their physical examination, then they don't tend to see the consequences of their decision, and so they may decide that actually no, CTs are always the correct and best way to perform a physical examination. And then lastly, premature closure. So premature closure is where we have a diagnosis made, and then we stop thinking, and we stop thinking about whether this is accurate or if there's other things going on, and that's quite strongly related to search satisfaction, which, like I said, is once we've made a diagnosis, we don't seek to see if there's any other diagnoses that might be the case, or if we've missed anything else. So, for example, where you've looked at a chest X-ray and you notice the lower lobe pneumonia, that ends up being an example of search satisfaction in that you've seen lower lobe pneumonia, but, for example, missed the rib fractures that have occurred also on this child, and be a potential NAI case, for example. So before we all decide that we're just going to hand in our resignation and stop our clinical practice, we need to take a breath and understand what James Reason was saying right at the beginning, is that errors tend to occur due to a whole host of reasons, and that we need to come into our working day assuming that errors can and are likely to occur, but that doesn't mean that we tolerate their occurrence. And that we need to identify situations that may increase the likelihood of error occurring. So those situations that we talked about earlier being the HALT, so wherever we're hungry, angry, late or tired, those may influence our processes, and that situations where we are unfamiliar with the task or inexperienced, they may also predispose to error occurring. And with that in mind, then we come up with contingencies to cope and to reduce interruptions and distractions, and where there's complex procedures in place, that those are mentally rehearsed. And other kind of suggestions that have been made in terms of reducing human factor error in medical practice is avoiding reliance on memory, making things visible, so having apps, having charts around, standardizing common procedures. So, for example, now there's been a lot of work towards having checklists for intubations, having checklists for transfers from the ward, from the ED up to the ward for sick patients, having transfers from ward to the CT scanner or that sort of thing, just to make sure that patients are safe en route, using checklists as aid memoirs, and decreasing the reliance on vigilance. So having stop points in the day that allow people to regroup and come up with a new jobs list, for example, or having like lists in order to write down things that need to be done. And in yourself, like we said before, know yourself, eat well, sleep well, and look after yourself, know your environment, know your task, plan for the what if moments. So for those kind of rare situations, for example, if you're coming to a new hospital, where's the resus trolley, where is the laboratory, where is the blood fridge on the neonatal unit, or on the on the labour ward unit, that sort of thing, that helps you to be prepared for those urgent situations. And where you don't know, ask. And in terms of the metacognition side of things, when talking about ascertainment bias and anchoring and cognitive bias and all that sort of thing, ask yourself, what else can it be, so that you don't fall into premature closure or search satisfaction, and ask yourself, is there more than one thing going on? always attempt to try and disprove yourself and write down a differential diagnosis, because then that helps you to widen your search and to think about the things that you might otherwise miss. So a useful acronym for when you're making diagnoses is thinking about serious diagnoses, what's probable in this situation, what might be an interesting diagnosis, what might be treatable. And if you kind of think about all those sorts of situations, then you're less likely to miss something rare. All right, and then just for 5 minutes, I'd like to talk to you about situational awareness. So who sees the rabbit and who sees the duck? Who sees the old woman? Who sees the young woman? It's all matter of perception, and sometimes we can get task focused and fixation error can occur where we become so, I guess, engrossed in the situation at hand that we may forget or we may miss the other things that are going on. And that often tends to happen in high stress or high level or areas where there is a high turnover, such as, for example, an intense neonatal unit, where you might be fixated on reintubating a premature baby and then miss the new admission who has come in recently with suspected HIE, who may be subtly seizing in the corner, as a kind of example. Or that you're in the ED and that you're seeing a patient with a very difficult cannula, for example, and spending a lot of time on that cannulation and missing maybe that there are 2 other patients in the department that are also needing attention and are quite urgent. So situational awareness is helpful for all of us to kind of incorporate in our working environment amongst the whole team in order to help reduce the likelihood of errors occurring because of fixation error. And to do that, we need to have a shared mental model. So shared mental model is where there is an understanding that is collective amongst the team about what the current situation is, and that understanding is shared through by all the team members through communicating with each other. And safety huddles have come as a result of this. So back in 2014, the Royal College of Pediatrics produced something called SAFE, and that stands for situational awareness for everyone, where they're meant to be quite brief 10-minute huddles in the middle of the day to stop and think about what are our staffing issues, what are our equipment issues, what are our drug error issues, or things like that, and who are the patients that are high risk, who are the patients that are deteriorating, how can we prevent them from deteriorating further. And stopping to have these little huddles in the middle of the day has been shown to markedly improve the amount of the amount of unpredicted admissions to intensive care units. And it was done because we, as a country in the UK, we noticed that we were much lower in comparison to other European countries for our morbidity and mortality, and we found that we're not very good at escalating deteriorating patients. And so the safety huddles and the Pews charts that are coming up soon are on the back of that, those findings. And safety huddles are an opportunity to invite everyone on the team to give their input. So everyone from the healthcare assistant and the cleaner and the ward clerk to the consultant on call. And it allows then everyone to be able to give their input and to voice any concerns that they have about the safety of patients on the ward. So they identify situations, then the huddle is used as an action point then so that people can mitigate errors or high risk situations, and then where needed they can escalate them to like higher places. And this has been expanded on at the Royal Free Hospital in terms of now incorporating it to allow parents to also be involved. So empowering parents, if you see something, say something, has allowed them to reduce their risk quite dramatically. And they've also incorporated them in bedside wall plans so that it has been used as a way of communicating with parents so that they can also know what the plan is for their child for the day, for example, scan at 2 p.m. or something like that, so that they then also can highlight when things are not happening. So for example, with the scan at 2 p.m., if it's gone 2 p.m. and the parent knows about it already, they can highlight it to the nurse and say, it's time, and we've still not been ordered to go down. And on the back of these initiatives, there's now new initiatives such as Huddles, which is a huddle for pharmacists and clinicians together to either look at, say, for example, drug errors that day, or to look at like a trend in the drug errors over a week or over 2 weeks, and just looking to see if there's any pattern to them or if there's anything that needs highlighting in order to help the clinicians who are prescribing to do a better job and to reduce medication errors. So I think we have a little bit of time left to quickly go through the quiz. So for anyone who is able to go on to the internet, go to kahoot.it, and we will quickly see how much we've understood. So I don't know if you can hear me over the noise. If you can go to kahoot.it and type in the pin 359474, and then we'll just quickly start. It's only a few questions. Fab, thank you. Can't see if we've got any more takers. Thank you, thank you. So I just saw a message saying, how can I log in? So if you go to kahoot.it, so www.kahoot.it, then you'll be able to join us. Okay, so I think we will start. Thank you. Okay, so here we go. So here we go. What is ascertainment bias? So you have 4 options and you have 20 seconds to answer. So ascertainment bias is that red when one relies too heavily on initial information given, when one overvalues that supports the first diagnosis, which is blue, yellow when one's emotions affect their clinical judgment, or green when one's thinking is shaped by prior expectations. So I think that was maybe a slightly difficult one to start off with, but yes, ascertainment bias is where one's thinking is shaped by one's prior expectations. Remember, the eye sees what the mind knows. Okay, all right, next one. Oh. When am I most likely to make a mistake? When I'm tired and hungry and have had a row with my other half, when I'm bored and understimulated and clock watching, when I'm totally refreshed and I've slept well, when my boss has told me he's leaving me in charge. Yep. So whilst yellow and green might also be areas in which I can make a mistake, the most likely situation is where I'm tired and hungry. And we go back to that alcohol, 24 hours of fatigue being the same as 0.1% alcohol level in the blood. Well done. Okay, so what is premature closure? So when a surgeon closes up the abdomen before counting the swabs, when Netflix glitches, when one reaches a diagnosis and doesn't think of alternatives, or is it a new type of cervical suture? Okay, so when one reaches a diagnosis and doesn't think of the alternatives. Okay, so question 4. True or false, 24 hours no sleep is equivalent to the alcohol blood level of 0.1%. Yep, I think that was easy. Well done. What is diagnosis momentum? So is it red when you're getting faster and faster at making a diagnosis? Blue when a patient is labelled with a diagnosis and becomes difficult to remove it? C, when you've seen a diagnosis many times, you also use it for the next patient? Or is it green when the diagnosis is made increasingly more complex? So nobody answered on that one. And what about this last one? Okay. They seem to be a little bit trickier than what people were expecting, maybe. Last one. Safety huddles and juggles are examples of improving what? Team bonding. Blue, team's abilities to drink a fast cup of tea. Yellow, team situational awareness. Green, team latent errors. Yep, team situational awareness. So well done, Summer. Well Beatrice? And AS, wherever you are, well done. Good job to everyone. So I don't know if I'm still. Okay, I don't know if anyone can still hear me. So we'll just quickly summarize. So we operate within a wider system, and that's where we think about the Swiss cheese model and the SEEPS model. We recognize that our brains are limited and that we have to actively take steps to reduce the individual risk that we have. We need to recognize those situations where errors arise, for example, if I'm hungry or angry or late or tired, and that we can use checklists to help us to think about how to mitigate those situations where risks are more prone. We need to think about our cognitive biases, like our ascertainment bias and that sort of thing, and think about split diagnoses. So what's serious, what's probable, what's interesting, and what's treatable, and think about those in terms of then when we make our differentials, and have that situation awareness, and encourage your team to have safety huddles in the middle of the day in order to try and think about how the day is going, what sorts of things have come up during the day, and what we can do in order to mitigate any deterioration of children. I'd like to say a huge thank you to Dr. Jane Runnacles, who helped with the preparation of these slides. And here are some resources which are also in the patient safety learning pack, so that you may have a look at those a bit later on at your leisure. Thank you very much for your time, and I hope you have a wonderful rest of your day. Tomorrow we're going to be joined by Dr. Annette Fogarty, who is an expert in root cause analysis, and we're also going to be joined in the afternoon by Dr. Simon Fleming, who is an orthopedic registrar, but who has a lot of experience in culture and patient safety, and looking at how those impact each other. So yeah, we're looking forward to seeing you both for both of those talks tomorrow. Bye.